that, we're very excited to host Dr. Colin Feuille. Dr. Feuille provides clinical care at Zuckerberg San Francisco General Hospital, where he sees patients with any gastrointestinal diseases and performs endoscopic procedures, including upper endoscopy and colonoscopy. He received specialized training in inflammatory bowel disease during his fellowship through the UCSF Crohn's and Colitis Disease Center. He currently pursues educational research focused on the role of peer teaching and endoscopy education. So, as all of us second and third years know, it's always a pleasure to scope with Colin and learn from him and learn how to teach from him. He's developed an innovative curriculum with others to teach senior GI fellows the principles of effective endoscopy education and provide supervised opportunities to practice teaching. He completed UCSF Teaching Scholars Program in 2024. So it's with great pleasure that we're looking forward to hear from Dr. Foy today on upper GI bleeds.
All right, thank you for the intro, Gloria. So I'm happy to talk to you today about non-variceal upper GI bleeding. You'll have a whole separate talk on portal hypertensive bleeding, which may or may not be more fun. But we're going to dive right in. Try to learn how to formulate a approach to a patient presenting with an upper GI bleed, including taking a targeted history, physical exam, and labs. You should be able to explain the medical and endoscopic management of upper GI bleeding based on the source in an acute setting. I hope by in this talk, the fellows will be able to propose the necessity, timing, and appropriate location of endoscopic procedures. And ultimately, we're going to spend a lot of time focusing on the most common cause of upper GI bleeding, which is peptic ulcers. And so we'll talk about management of those, including pre-endoscopic, endoscopic, and post-endoscopic therapies. So by way of a brief intro, when we say upper GI bleeding, we're really talking about any bleeding that's coming proximal to the ligament of Chartres, which is basically kind of somewhere in the duodenum, crosses somewhere between the third and fourth portion. So all of our esophageal, gastric, and early duodenal sources are considered upper GI bleeding. Anything distal to that is until the colon is basically small bowel bleeding, and then the colon is considered lower GI bleeding. And Wasim is going to give you a talk on lower GI bleeding in a couple of weeks. So upper GI bleeds are very common, probably one of the most common reasons for people to be admitted to the hospital with a GI problem. It accounts for about 250,000 annual ED visits and 200,000 annual hospital admissions. There for a while, actually, incidence of upper GI bleeding had been decreasing, but in the last 10 years or so, we started to see an uptick in the rate of the incidence of upper GI bleed for reasons that are not entirely clear. We had, kind of initially attributed increasing PPI use for things like GERD and dyspepsia, and more recognition and treatment of H. pylori as possibly driving that decrease over the decade between 2006 and 2014. But it seems to be increasing recently for reasons that I'm not entirely sure about. Again, want to make this somewhat interactive, like we just talked. So for our new fellows here, if you have not already, you may very soon be getting a text page like this about someone found down in a pool of coffee ground emesis and melena who's tachycardic and hypotensive, paging you from the ED. So Mason, what do you want to know about each of these? Like what are you going to focus on when you're taking a history in terms of like the character of the bleeding, what comorbidities, meds, substances, procedural history, what will you focus on in your exam? Just start throwing some things out.
Yeah, I think there's a few things if he's found, but whatever history we can get. Otherwise, whatever history we can get, if there's like bystanders or loved ones that he lives with in terms of recent exposure, in terms of alcohol, drugs, things like that. We can check his chart, his history of like cirrhosis, which would make us think a little bit more about variceal bleed and need for things like octreotide. If he's taking any blood thinners or had any recent procedures or thinners, aspirin, NSAIDs. I guess also if he is somebody who was born from in a different country or recently traveled to a different country. Again, all of this is probably, like we'll find a lot of this out later since he sounds pretty unstable, but and then any past sort of abdominal surgical history, any prior scope history that we are aware of, cross-sectional imaging that the ED might have, and then on exam, I guess, generally how he looks, is he mentating, or sorry, he or she mentating, what does the abdomen look like? Is it distended, tender? And then if they're actively bleeding from above or below, we want to visualize that directly. And then if not, we can DRE them, but it's kind of a moot point if we visualized blood and they were found down in a pool of it. I think those are
Great.
kind of the major things.
Yeah, awesome. Love it. Alexander, any other things you would add there?
Sorry, could you say that one more time? I missed
Oh,
that.
Alexandra, anything else you would add there? I think you covered really a lot of the key things in this and some other ideas.
Um, sorry, Mason and I are sitting next to each other, so
Oh,
sorry. But I agree. I agree with his very thorough history. Yeah, looking for, recent travel history. I think getting a good time course as well for the bleed, any preceding symptoms as well, like dysphagia, family history of gastric or colon cancers, like Mason talked about, comorbidities like liver failure. I think even guiding this talk really help us differentiate the etiology of the bleed. And I think that's largely it.
Great, yeah. So, as a key history questions, how long has it been going on? How much, how frequently, what type of bleeding? Is it melena or hematemesis or hematochezia? You asked about any other associated GI symptoms that might point to a particular cause of bleeding, like if they're having dysphagia or dinophagia, maybe it's more of an esophageal source. And then I would ask about orthostatic symptoms or signs of more severe anemia like dyspnea, chest pain. You mentioned a lot of the key kind of comorbidities, liver disease, coagulopathy. Would want to know about significant cardiopulmonary disease because that might be someone who we have managed a little bit differently in terms of like how urgently we resuscitate them. And then you already covered a lot of the key medications and procedural history. And then the other things that you start to think about as a proceduralist, and not so much as an internist, but ask your kind of pre-procedure questions. So like when was the last time they ate or drank, and are they consentable? And as Mason already pointed out, we're going to focus on certainly the overall appearance, the abdominal exam, and then we definitely want to do a rectal exam if we haven't visualized any kind of stool. And we're really looking for, are they having melena or essentially it's that kind of dark, tarry, sticky stool. Again, you know it when you smell it, and you're going to smell a lot of it during first year of GI fellowship. It is melenic when you're using it as an adjective, not melanotic. Melanotic is referring to melanin, like in the skin. And you actually don't need that much blood loss to cause melena. It's, as little as 50 cc is like the size of those small liquor bottles they give you on a plane. It's actually enough to get digested and turn stool melenic. And so when we're looking at stool or any kind of GI bleeding, we really care about the color. So if someone is having brown stool, they are, unless they're like vomiting the frank blood, they are probably not having a large volume of a GI bleed because you don't need that much bleeding to cause melena. And in general, melena is going to point to an upper GI or a small bowel source. Hematochezia, a bright red blood per rectum, typically is going to be more of a lower GI bleeding etiology, with the exception being if there is a large volume upper GI bleed in a patient who's unstable, like tachycardic or hypotensive. I would still be worried about an upper GI bleed because that blood hasn't had time to get digested and turned into melena. As you all know, no one cares about the FOBT test. We've been trying to get that out of practice, but really should not influence clinical decision making. Finding melena is a clinical diagnosis. So again, focus on orthostatics, whether they're getting better with resuscitation, overall appearance, and the key thing that you really want to get from your exam is, are they stable or unstable, and are they having signs of ongoing active bleeding or not? Very small amounts of blood loss are not going to have much effect on heart rate or blood pressure. When you start to lose more than about 800 cc's of blood, you're going to start to see a drop in the blood pressure by about 10 and an increase in the heart rate by about 10. And then once you start to lose about 1,500 cc's of blood, that's when people start to get kind of shocky. And so they're going to need more aggressive resuscitation. You may still see this kind of thrown out as an idea somewhere about putting in an NG tube to do a lavage to try to help figure out where the bleeding is coming from. It's in practice not all that helpful. A true negative NG lavage should return bile, and in theory that's because the NG tube tip is placed past the pylorus somewhere in the small bowel. So in theory you're aspirating duodenal contents. Unfortunately, the predictive value of this is not all that great. About 15% of those who have a negative lavage are actually ultimately found to have high-risk lesions when you go and scope them. And then up to 40% of those who return frank blood on the lavage actually have low-risk lesions, like a clean-based ulcer. So it doesn't influence clinical decision-making all that much. I would not put an NG tube in someone just to do an NG lavage. if someone has been in the ICU intubated for something else and they have an NG tube for feeding, then by all means go ahead and aspirate what's in there. But again, a very limited role for that right now. So now that you are starting to see this patient, you've got paged by the medicine team. Mira, what are you going to recommend to the primary team for resuscitation?
So for our unstable bleeder, first going to make sure that we have good access to large bore IVs, make sure that we are prepping blood products. And at this point, I'm sort of like thinking that we may need to do, in addition to blood, potentially platelets and FFP as well. And then thinking about crystalloid as needed to temporize for as long as it's going to take to get the blood to us are some of the main things that I'm thinking about, just getting that process all started.
Great. And what do you mean by large bore IVs exactly?
Yeah, I think it's like 18 gauge or bigger.
Great. Yeah. So yeah, generally 18 gauge is what we want to shoot for if they have good enough veins to get 18s in. But the color coding for PIVs is green is 18, pink is 20, and blue is going to be 22. And we really like the larger bore IVs because of Feuille's law, which was one of the main reasons that you have to take physics to get into medical school, which basically dictates that flow is proportional to the radius to the fourth power and inversely proportional to the length of the tubing. So you want a short, fat IV to get the maximum rate of flow. And if you compare like the 18 gauge ports of a peripheral IV with the 18 gauge port, same size of a triple lumen, which is a much longer catheter, you can see that you get much higher rates of flow with the peripheral IV. So short, large peripheral IVs, those are your preferred. Get 2 of those and you're good to go. Someone who's like in really like hemorrhagic shock and going to the ICU, we might think about putting in a Cordis, which is a really large bore central line. That would certainly be the preferred central line compared to a triple lumen if you are needing to do that for someone. They'll kind of frame the rest of this talk based on current guidelines. Our most recent US guideline from the ACG is still from 2021. That I would imagine will get updated at some point in the next couple of years because the Europeans have just come out with their update this year. So I'll mostly use the ACG guideline as the frame for this talk, but I will point out some areas where the European guidelines have deferred a little bit with our current ones. It is recommended for most people with upper GI bleed to do some kind of risk stratification. We in this fellowship don't so much see patients in the ED as consults, and so I think something like the Glasgow-Blatchford score is really most important for our ED colleagues to be using because it is best validated for predicting low risk GI bleeding. Someone who has a score of 0 to 1 on that has very, very low risk of mortality and can likely safely be discharged from the ED and get an outpatient EGD. So these patients you probably won't even be called about because they're just going to get a consult to GI for outpatient follow-up. There is another more simpler score called the AIM-65 score, just based on the albumin, INR, altered mental status, hypotension, and age, which is best validated for predicting mortality. So once you get to a score of 3 and above, you're looking at like 10+% in hospital mortality rate. So this is not really for deciding who to discharge, but it can be helpful when you're talking to the ICU triage team about who to potentially admit to the ICU because they might have a risk for poor prognosis. All right, so Mira already alluded to this a little bit, but we were thinking about transfusions, and so Nicolette, what do you recommend? And just going on, to another level, is there data to support your recommendations for transfusions when talking to the team?
So generally for transfusions, we recommend transfusing to a hemoglobin goal of 7 or 8 if they have cardiac disease. Although if it's like a particularly brisk or like unstable patient, I think we would recommend like transfusing to like more of like a blood pressure goal as opposed to a particular hemoglobin target. And as Mira alluded to, typically we start with blood, but the more product that we're giving, we need to match like that with platelets and FFP. And I'm not really sure about the data to support those recommendations.
You're right on, and so the data is over 10 years old at this point, but our landmark RCT on this was from was in the New England Journal in 2013. At this point, it's just kind of accepted practice. But we do recommend generally a restrictive transfusion strategy, which is a hemoglobin target of 7. And that was essentially had lower mortality compared to the more liberal transfusion strategy, which you can see in the subgroup analysis, was actually really driven by the people with child A and B cirrhosis. As you'll learn in the portal hypertensive bleeding thought, the thought there is that over transfusing patients with portal hypertension can kind of raise the portal pressures and increase the risk of bleeding. But in general, there was clearly better outcomes with the restrictive strategy in terms of overall survival. And as you noted, this excluded massive exsanguinating bleeding. So we do not apply these results to people who are in hemorrhagic shock. Those people should be transfused essentially with using blood as your resuscitation fluid. And so you can consider massive transfusion if you're transfusing over 4 units of RBCs over an hour. And in that case, we usually do kind of a 1-to-1 RBC FFP to platelets to essentially replace whole blood. Remember also that the hemoglobin that you get in the lab value is a concentration. It's grams per deciliter. And so that actually needs time to equilibrate. The reason the hemoglobin drops is because the extravascular fluid is going to diffuse back into the vessels. Also, the crystalloid that you're getting for initial resuscitation is going to, all that is going to dilute the hemoglobin value down. And so when someone immediately starts bleeding and immediately vomits up a ton of bright red blood, if you check their hemoglobin right then and there, it's probably going to be normal because what they have lost is whole blood and their concentration of hemoglobin is the same. But over the next couple hours, it's going to drop a lot. So people who are hypotensive, you don't want to wait till they get down to 7. And as Nicolette mentioned, we use a higher target for people with pre-existing cardiovascular disease. And an even higher target for those who are actually having an acute MI, who are having ongoing bleeding, or have risk factors for reinfarction, like poor cardiac anatomy. And this comes from most recent cardiology guidelines published in 2025. And the rationale for this comes back to physiology. Ultimately, you need blood to deliver oxygen to tissues, and the delivery of oxygen is proportional to the cardiac output, the hemoglobin, and the oxygen saturation. So if you have a bad heart or bad lungs, you're going to need a higher hemoglobin level to make up for the lower cardiac output to maintain oxygen. All right, Jessica, should we give this patient a PPI? What is the evidence and what do the guidelines say?
Well, I feel like if we suspect that there is an upper GI bleed, then usually do IV, PPI, BID.
Great. Yeah. And what is the evidence for that?
Not sure.
That's all right. So actually the data overall on PPIs, at least before endoscopy, are kind of modest in terms of their actual effect. So giving PPI before endoscopy does not affect overall mortality further or rebleeding rate, as well as need for transfusions. What the PPI does seem to do is decrease the need for therapy during the endoscopy and the rates of finding high-risk stigmata. So what we think is kind of happening is that getting the PPI on board, the rationale for giving acid suppression is that your platelets work better at a neutral pH. And so if you can kind of optimize your clotting function, you can start to allow that ulcer to clot off and to start to heal. And so by giving the PPI before you scope, you probably scope 12, 24 hours later. We'll come back to the timing in a second. But you're allowing that ulcer to start to heal, and so you may kind of downstage the lesion. And you may not need to do as much therapy. Clearly, people who are ultimately found to have high-risk ulcers, do benefit from intensive PPI therapy, and they're going to have decreased rebleeding. It's also probably a good idea to give the PPI because if the endoscopy is going to be delayed or not done for some reason, like for example, that patient who is having an acute MI and needs to go urgently to the cath lab, at least you're getting the PPI on board to start to stabilize the situation before you go in and scope. There is pretty good data at this point to support that IV PPI, BID, and IV infusions are pretty equivalent. And so we've generally moved away from using the IV drip because just more volume load, they're picking up IV continuously as opposed to just giving it twice a day. So Because the data are relatively modest, the actually ACG recommendation didn't give a recommendation for or against pre-endoscopic PPI, although the European guidelines do suggest high-dose intravenous PPI therapy. And our practice here generally is to give a large IV bolus of pantoprazole, 80 milligrams, and then move to 40 milligrams BID. And we start that right away. And then you're going to modify the PPI based on the endoscopic findings, which I'll come back to towards the end of the talk. And again, there's giving this PPI up front may lead to cost savings because you're not needing to do as much therapy and using all the fun tools that we have during endoscopy. As we'll talk about later, people who have low-risk lesions often can be discharged more quickly, and so that may save you a couple of days of hospitalization cost. And again, this is also starting that intensive PPI therapy earlier for those patients with high-risk ulcers who really do need PPI to help those lesions heal. All right, Christine, is there any other medication we should give before we scope? And this is something that may make your job easier during the endoscopy.
With the hint, I'm thinking about motility agents like erythromycin.
Great, yes. Did they do that at MGH?
Not very frequently.
Yeah, it doesn't mean it's in the guidelines, but I think in practice something that we either forget about or like just can't like get everything coordinated. But we do, the recommendation is generally to give erythromycin about an hour before you scope, and the rationale for that is that erythromycin is a motilin agonist, so it's an antibiotic, but we don't really actually use it much as an antibiotic anymore because it stimulates motilin, which is a promotility receptor, which meant that people got a lot of gastric upset and diarrhea when they would take it. But that means it is a good prokinetic. And so it does seem to allow you to see better, which then decreases the need for repeat endoscopy and maybe the decreased length of stay. Issue with this, that can take a while to get from pharmacy. It does prolong the QT, so you need to check that beforehand. So this last issue, I think, is really the main one that makes it a little bit difficult to do. But these are the ESG light outlines in a little bit more detail some of the scenarios where you might really think about giving it. And it's really, acute upper GI hemorrhage, fresh blood, and your clinical suspicion is pretty high that you're going to scope them and find ongoing blood and clots. If someone has been stable for a couple of days and was waiting through the weekend to get their EGD on Monday, there's something that's probably not going to be full of blood anymore, and so you probably don't need to give it. But someone who's in the ICU who was like actively having hematemesis, it definitely is a good idea to think about doing this. And the other option is metoclopramide, which is certainly much more readily available. It's often like just stocked in the carts, like in the ICU, and so you can just give your 10 milligram IV push of that. But in 2021, there was not a lot of evidence for it, so it was not endorsed by the 2020 in the ACG guidelines. But the ESG, based on some data that came out in the last few years, did an updated meta-analysis, which suggested significant improvement in mucosal exposure and endoscopic visualization, and no difference in blood transfusion and length of stay, with a trend towards reduced need for second look EGD. So you can see kind of both these like forest plots suggesting that they're favoring metoclopramide for these outcomes of adequate mucosal exposure and requirement for second look endoscopy. So they do suggest in their guidelines that if you can't get erythromycin, that you do give pre-endoscopy IV metoclopramide in similar patients who you would consider giving erythromycin to. All right, Alyssa, when should we scope the patient, and is there data on the timing of endoscopy?
I think there's some evidence that I'm not aware of that suggests in like more hemodynamically unstable patients, they should be scoped within 24 hours. And in patients who maybe are more stable, we allow them time to allow the PPI to downstage the lesion and then scope them at some point once they're medically optimized during the admission.
Yeah, so generally I would say, 24 hours is, our target for most patients, especially those who stabilize. But there was a 2020 RCT published in the New England Journal that randomized patients to who had a high Glasgow score, randomized to urgent versus within 6 hours versus early within 24 hours endoscopy. And this did exclude patients who were in hypotensive shock or patients who were unstable despite initial resuscitation. So This group here in red might be the ones who you would actually think about coming in overnight and doing the endoscopy more urgently. Because essentially, like if endoscopic therapy and hemostasis is going to be needed to actually like stabilize the patient, then that might be a reason that you need to do it earlier. But otherwise, if they're responding to resuscitation and they're on the floor, you're looking okay, you generally can wait till the morning. But we usually recommend doing the endoscopy within 24 hours because in this group who did stabilize, there was no significant difference in 30-day mortality, further bleeding, duration of hospitalization or transfusion. The main difference is that the urgent group required more endoscopic therapy, which makes sense because again, it was less time for the PPI to work its magic and downstage those lesions. Varices are a little bit more urgent. We do recommend scoping those within 12 hours. And again, sooner if they're unstable, and that's based on the VMO guidelines, which you'll hear about more later. And now as a procedural team, you need to start thinking about some of the like logistical considerations of where you're going to scope the patient. So we generally can do endoscopies in the ICU, obviously in our endo unit, as well as in the OR. So endo is generally open only on weekdays, and so anyone who is not in the ICU and stable to come down is going to be able to be done in endoscopy. If it's a weekend and you want to do a case, but they are not in the ICU, you generally have the option of doing it in the OR. And then in terms of anesthesia, anyone who's having active hematemesis or generally anyone who's like unstable enough to be in the ICU probably should have general anesthesia. If they are stable enough to come down to endoscopy and they're not having hematemesis, those are good candidates for MAC. And Maud said, maybe an option for people who are very stable, i.e. that person who's been waiting all weekend and their hemoglobin's been rock solid stable, their comorbidities are otherwise acceptable for Maud said. That patient probably has a very low likelihood of needing endoscopic therapy, and you may consider doing them with moderate sedation. So again, before we go in and scope, think about have they been adequately resuscitated? Again, those massively bleeding patients, really, you just need to get them stable enough to induce anesthesia that you're not going to like tank out their blood pressure when you induce. But some of those patients may need a more urgent scope, just actually help them stabilize. Do they have good access? Does the ICU team need to put in an A line for those patients who are maybe going to need pressors? And then think about how long they've been NPO. So if they've been for clears, generally need to be NPO for at least 2 hours before a scope. And for solids and full liquids, it's generally somewhere between 6 to 8 hours, depending on exactly what the consistency of what they ate was. Obviously, someone who needs an EGD more urgently, before one of those time windows, we can still do it as an emergent case. Just anesthesia needs to know because they will need general anesthesia with a rapid sequence induction. And remember to get consent if the patient is awake and consentable. Remember to get that consent before they get intubated. Obviously, if they were found down and immediately intubated in the ED, then you have to find a surrogate to do the consent. All right, Sean, what are we going to find when we scope someone? What are the most common causes of upper GI bleeding?
Non-variceal, you mean?
Yes, non-variceal.
Like you said, peptic ulcer disease probably is the most common. But kind of going top down, otherwise you might find Mallory-Weiss, advanced esophagitis, other things in the stomach, kind of more zebras like AVMs, GAVE, Dulafoy. Those are kind of the big things that come to mind initially.
Yeah, you've got a lot of these. So to varices, peptic ulcers. I think you mentioned really all of these here. And then there's the real zebras like aorta or enteric fistulas, like hemosuccus pancreaticus, hemophilia, maybe someone who's like just had an ERCP and is having a post-sphincterotomy bleed. So yeah, these are some of the things we'll be thinking about. I'm going to spend most of the time on peptic ulcer, but just cover a few of these other ones quickly. So severe esophagitis, we grade based on the LA classification. Certainly someone who has pretty gnarly looking LA grade C or D esophagitis. That can definitely present as acute upper GI bleed with hematemesis or off-ground emesis. The kind of a little bit related is Cameron lesions. These are these erosions or ulcers in someone who has a large hiatal hernia, and it's thought that they form because of friction of the hernia sliding up and down through the diaphragm, and you often find them at the diaphragmatic hiatus, and that leads to kind of like erosion, some disruption of the local ischemia, and that friction is what causes these. Predominantly, these, I would say, present more with iron deficiency anemia than with actually acute upper GI bleeding. Although, as you can see in the picture on the right, you can find some that are more actively bleeding at the time of the spill. Mallory Weiss tear you mentioned, that is a mucosal tear at the GE junction. And the classic history you would get there is someone who starts vomiting or retching, and it's initially clear or just gastric contents. And then after a few episodes, it then turns to blood because that's not the force of the retching itself is what causes that mucosal tear. These do often self-resolve, but sometimes can be kind of deep enough that they need, that they can cause ongoing bleeding and need endoscopic therapy. So here's a picture of one that would have gotten some kind of cautery to treat. Doulafoy lesions are these aberrant large caliber submucosal vessels that erode the overlying epithelium without a primary ulcer. So these can actually be really difficult to find because sometimes you get lucky and you find one that looks really prominent like this, but more commonly it's just like kind of flat mucosa. And if it's like actively spurting, you're going to see where it's coming from. But otherwise, it can kind of recede into the underlying mucosa and be very difficult to find if it's not actively bleeding. All right. So Shohei, if we scoped this patient who was found down in a pool of melena, and you found this lesion, the duodenal bulb, how would you categorize it?
It's a great question. I am not too sure. Oh, I guess it's like the forest grade.
We went over this in the endo course. They had this on their canvas. So the first year should have some knowledge to this, Colin.
Thank you, Tanya.
Thank you. Yeah, I think it depends on like if the clot is visible and if this is a bleeding vessel, and also if the vessel is not bleeding but like clot is visible. I think it's like the forest classifications. I think type 1 is like active bleeding, but I can't remember type 2 or type 3. There's also A and B, but I don't remember the specifics yet.
Right. Yeah. So it is the forest classification, and you're right. Type 1 is active bleeding, and if you're looking at this lesion here, what do you think this like red nubbin right in the center of the ulcer is?
It looks like a clot there.
So it could be. A clot usually would be more kind of dark.
Okay.
This is a little bit kind of raised up above the ulcer bed.
Like
do you have any want to help out?
The visible vessel?
Yeah, so this is a non-bleeding visible vessel. And so this is the forest classification for peptic ulcers. So 1A is that arterial jet, like spurting. We don't see this too often, but when we do, it's like very dramatic and great to capture a picture of. And then 1B is active oozing. These can be, also lower risk stomata underneath, but you just clearly just see an ongoing ooze. And then this is also a really good picture of a visible vessel. It's usually this kind of like somewhat raised nubbin in the middle of the ulcer. 2B is an adherent clot, so that's going to be more of it like dark clotted blood stuck onto the ulcer. 2C is a black or pigmented spot, so that just may be as opposed to the visible vessel, which is raised. This is going to be a flat, usually red, circular lesion in the middle of the ulcer, probably as like a vessel that's already like healed over a bunch. And then forest 3 is your clean ulcer base, so just like white across the whole base of the ulcer. And these are important because the forest classification dictates the risk of rebleeding and also therefore the how necessary it is to do endoscopic therapy on these lesions. So obviously something that is like actively spurting in front of you is almost certainly going to continue to bleed or rebleed if you don't do anything about it. So you're definitely going to do endoscopic therapy. And certainly anything that's oozing, those, if it was something relatively low risk underneath, may stop on its own. But obviously, since it's actively bleeding, we're going to do some therapy on it. These non-bleeding visible vessels, so again, it's this vessel sitting right there in the open, those are very high risk of rebleeding. So those also need endoscopic therapy. On the lower risk end, these flat pigmented spots and clean ulcer bases have very low risk of rebleeding. And so you don't need to do any endoscopic therapy. The body has already started to heal those, just let it kind of do its thing. The adherent clots are somewhere in the middle. And the reason for that is because what's underneath the clot, you don't exactly know. It could be something really high risk, like a vessel, or it could just be a pigmented spot. So the rebleeding rate is more variable. And so it can pose a little bit more of a challenge about what to do. So maybe one of our second or third year fellows, what would you do with this lesion? I don't see anyone's camera on.
Colin, it looks like this is a lesion that's not actively bleeding. But we like just like we do with even actively bleeding ulcers, once we achieve hemostasis, we'll have them come back in a period of weeks or months. And the reason we do that, actually, I was just scoping with Myung. We had a case like this, an outpatient POSC yesterday where she had upper GI bleed a couple of months ago, coming back, and now we're sampling this area for dysplasia, for cancer surveillance, for malignancy surveillance. So sampling a lesion that might be concerning for dysplasia or metaplasia is important. That's what I think about when I look at this image.
Yeah, so I agree. It's not actively bleeding. There's maybe a little bit of kind of ooze around it, but there is this like big dark clot here. So definitely, any ulcer we're worried about, we're gonna want to have them come back and rescope them, which we'll talk about at the very end. But do you want to do anything to remove this clot to see what's underneath?
Yeah, so in the context of hemodynamic instability, or recent hemodynamic instability, then unroofing the clot may be something that is reasonable so that you can provide a definitive intervention.
Yeah, so in terms of what the guidelines say, the ASG does not give any recognition for or against endoscopic therapy. They do suggest that you start by at least like vigorously washing the clot, and if that dislodges it, then and you see something underneath, then you can go ahead and treat whatever that is. But as far as doing anything more than just washing, they don't recommend anything in particular. The ESGE is a little bit more aggressive. They do suggest that you should try to remove the clot and do endoscopic therapy, assuming that you are confident and confident in being able to then do that safely and then treat whatever you unroof underneath. So consider doing a little bit more than just watching something like this. And so you put on your brown pants and they inject some epinephrine in here to maybe temporize whatever is underneath, and then you could use a snare to unroof remove the clot and see what's underneath, and then I guess it probably unveiled some high-risk stigmata because they treated it with a few clips there. So again, especially in someone who had a significant GI bleed, you do think about treating those, unroofing those clots if you feel confident managing what's underneath. All right, so let's talk a little bit about what some of the tools that we have to actually treat upper GI bleeding. So we're not going to talk about banding because that's really more used for varices, but we'll cover kind of all of these different tools. And we'll start with epinephrine injection, which is basically just injecting 1 to 10,000 dilution of epinephrine directly around the vessel. Because it's causing local tamponade as well as vasoconstriction, it can help by just to slow down or stop some of the active bleeding or oozing, which can improve your visualization. But because it's just injecting a medication locally that is eventually going to diffuse out and wear off, it's not going to provide durable hemostasis. So it is not good for monotherapy. But we do recommend for people with actively bleeding ulcers doing combination therapy with epinephrine as well as some other modality. And you and ICU team should be aware that when you inject this, it's not, some of it is going to diffuse systemically, and so you're watching the monitor, you're going to see their heart rate and blood pressure jump up after you inject epinephrine. Once we've done that, we might think about doing something like bipolar coagulation or gold probe. This has a lot of data that it reduces bleeding and mortality. And the technique here is to apply the probe directly to the bleeding site and apply firm pressure. You're going to use the blue or coagulation pedal on your electrosurgical unit. And hold it down for like 8 to 10 seconds. And you really want to get a good burn on that lesion to seal off the blood vessel. You can shoot some water either directly through the gold probe or through your scope to help unstick the lesion. And sometimes once you've been burning for a while, it can get a little bit like the gold probe kind of stuck there. The gold probe does come in 2 sizes. There's a 7 French and a 10 French. The size you use is dictated by the scope you're using. So if you have a therapeutic or T1 scope, you can and should use the larger gold probe because that just gives you more surface area for contact with the lesion. Depending on where the lesion is, you can either put the probe on FOSS directly onto the lesion, or you can go by the side. So in the lower picture here, you can kind of press the probe against it. And so anywhere the gold coils are, you're going to get that coagulation. All right. We also, on the other kind of heat therapy that we have is hemostatic forceps or hot biopsy forceps. These you can use to grasp, like a grasp a vessel, and you're going to use soft coag mode with 1 to 2 second bursts. And really, again, the goal is to like grab that vessel, apply heat all around it, and then start to seal that vessel off. There was a small RCT a couple of years ago, only about 100 patients or so, but with high-risk lesions showing increased hemostasis and decreased rebleeding compared to standard through-the-scope clips. And there were similar results in a meta-analysis with actually quite dramatically lower odds ratios for this compared to other modalities, which again, this was primarily through-the-scope clips. All right, so these clips, while we certainly like we do reach for them in a lot of cases, there's less robust evidence for peptic ulcer treatment compared to coagulation. There was in a few trials there was no difference compared to thermal contact therapy, but the confidence intervals were pretty wide, and so the grade of evidence for using those is a little actually lower than for coagulation therapies. But the idea here is to place them, over the bleeding site as well as ideally on either side. And the goal is that you're hopefully like grabbing whatever vessel is underneath the ulcer and sealing it off as well here. So here you can see like a non-bleeding visible vessel, and they get 3 clips on, one kind of in the middle, probably right on top of that, and then a couple on either side as well. What can be challenging with these is that sometimes, especially more chronic ulcers, can be quite fibrotic, and so it can be difficult to actually grab the ulcer tissue with these clips. And especially if, for smaller ulcers like this, where you can get the sides of the clip on either side of the ulcer, this looks like a really good target for clipping. But for a larger ulcer, where if the clip is only going to grab kind of fibrotic ulcer base, it can be very difficult to get these on target. And so for a lot of the larger ulcers with a non-bleeding visible vessel, I tend to reach for gold probe over clips. But here's one in the duo where, for example, just like more of a small vessel, not really a big ulcer, pretty good target to get a clip on here.
Is there ever a rule for gold probing and clipping, or do you kind of just?
Yeah, you can combine any of these therapies. I probably would obviously you're gonna gold probe before you clip, because once you clip something, you're not going to be able to get the gold probe on there again. But if you gold probe and you're maybe not so happy about how it looks, or maybe there's still a little bit of oozing and you're not quite able to get with the stop with gold probe, maybe consider putting a clip on as well. So you can combine these different modalities. Good question. So the larger clips are the over-the-scope clips, or TSC, or we often refer to them collectively as Ovescos, although that is the manufacturer name of probably the most widely available and most widely studied brand of over-the-scope clip. And these initially were primarily recommended to be used for recurrent ulcer bleeding as like a salvage or second-line therapy, and that's certainly where the strongest recommendation to use them. They clearly have less rebleeding compared to standard clips in patients with recurrent bleeding. But there have, in recent years, been more studies about using these as initial therapy in non-variceal upper GI bleeding. And they do seem to show decreased rebleeding, complications in infusions compared to quote, standard therapy. Although really a lot of the comparator arms in these studies, the standard therapy has primarily been through the scope clips, which, as I already mentioned, there's I think some limitations to clip use for a lot of ulcers. And so we actually have less good data comparing over the scope clip with effective gold probe use, at least when we're published in the literature. But and the benefit in these does seem primarily for high-risk stigmata. All of these studies have had methodological limitations. They're pretty much all sponsored by Ovesco, the manufacturer. And again, this randomized trial, the hemostasis rate through the scope clips was only 73%. That probably is a lower success rate than you would typically want from your initial hemostatic therapy. And if you were using gold probe, and this is actually just using it alone, they weren't even doing epi pretty much in all of these. So they weren't really necessarily doing optimal therapy with quote standard therapies. But the meta-analysis again overall suggests that there is some lower rebleeding procedure time. Tanya, at this point.
Hi. Can you standard therapy? Monotherapy with clipping is equivocal. There's nothing to say we should do epi now for clipping, right?
Yeah, so
that's not superior. Monotherapy with clipping, just so the fellows understand that monotherapy with clipping is standard of care. Like you don't need epinephrine, right?
You don't necessarily need it, although the guidelines do suggest for higher risk lesions that combination therapy is suggested. The data for that is not super strong. I think it's a conditional recommendation with like low quality evidence, but it isn't, at least in the ESG guidelines, it suggests you do combination for those like forest 1A, 1B lesions.
Combination, are they specifically discussing like epi as the adjunct, or is it coag plus clipping?
Yeah, so in the ESG guideline does recommend for actively bleeding, they recommend specifically epinephrine plus a second modality. The recommendation.
I find that epi, I don't know, maybe it's because
for-
I'm bad at clipping,
That's
but
for active.
For active.
Yeah, I guess I just want you to clarify. That's for active bleeding so you can see. But I think I just want to make sure you clarify, like, you don't need epinephrine and clipping. Like monotherapy with clipping is sufficient. All the
Right.
when they talk about the trials aren't doing gold probe and clipping. So I think I would just clarify this so that there's clarification.
Correct. Yeah, they're doing, for anything for non-bleeding visible vessel, choosing one or the other in most cases is sufficient, and that would be a standard of care. I think what I was getting at is that a lot of these cases, standard therapy has not included you're actually using gold probe in a lot of these trials, which I think in a lot of scenarios with a non-bleeding visible vessel, gold probe probably has more robust evidence for use. It depends on obviously the morphology of the lesion and how easy it is to get clips on, but. So we don't have as good data comparing over the probe as initial therapy to both of them.
Hey, Colin, this is Amandeep. Just to piggyback off what Tanya's saying, I think that the dual therapy is recommended if you're using epinephrine monotherapy. So we know epinephrine monotherapy is not sufficient and you would need something else. But to Tanya's point, mechanical hemostasis as single therapy can be sufficient to treat these ulcers. But the dual therapy comes with epinephrine therapy.
Yes, agreed. So another tool that we have is APC, or argon plasma coagulation. This is your modality of choice for angioectasia or AVMs, as well as GAVE. So AVMs are these vascular malformations that can appear anywhere in the GI tract, these kind of red spidery lesions. And then GAVE is ectatic mucosal vessels, antrovascular, which again, more commonly is going to present with low-grade bleeding and iron deficiency anemia compared with acute bleeding. Banding is actually good here as well. You can use bands to grab the underlying vessels there. But so when you're using APC, you kind of just like put this probe a little bit over the lesion, but not directly painting, and it's going to spray kind of superheated argon gas directly on the lesion, which is going to coagulate the underlying lesion. And again, there's only the blue pedal on the APC. These are some of the suggested settings, and you just kind of can paint, small, just tap the pedal periodically to paint the lesion and spray the gas on there. Finally, we have hemostatic powders. The two probably most commonly used that we have available here are the hemospray, which is made by Cook, or Endoclot, made by Olympus. These are basically, they're both powders that polymerize in the setting of active like blood, or really any kind of like liquid, and they're going to adhere to it and then help this like lesion clot. They do that, all that white powder is going to slough off after 24 hours. So there is some concerns about using those in higher risk lesions because of the risk of rebleeding once that powder goes away. It can be a little finicky to use, especially the hemospray, because it is going to kind of clot onto anything liquid. You need to really rigorously dry your suction channel to have the catheter that you're spraying the powder through not get clogged with the powder. Some of the most common scenarios that will reach for this is malignant bleeding. So tumors that are kind of diffusely oozing that don't maybe necessarily have good targets for endoscopic therapy. This is a good use for that. And also it's kind of your salvage therapy when you failed all other endoscopic therapies. The things that one of our other bleeding sources is cancers, which gastric cancers can sometimes just look like these gnarly ulcers, which is the reason why we're going to want to rescope a lot of patients with ulcers to make sure that they heal. But sometimes these can be really just diffusely oozy, and so there's less of a focal target for therapy there. But clearly this lesion is actively bleeding, and someone who is having an acute GI bleed, you might want to do something to treat it. Sometimes you can actually just do like APC and kind of spray it all over the lesion and see if you get some coagulation there. But sometimes you find one like this that's like actively spurting, and And maybe you get lucky and get some clips on, but if you don't, then this is, you're just going to spray hemospray and just call it a day. So that this is kind of a good to go to things like really diffusely bleeding kind of malignant lesions. Finally, there's topical gel or Puristat, which is this self-assembling peptide, which forms this like matrix-like structure. It's going to look like this kind of clear barrier over the lesion. I think our advanced colleagues use this really frequently to help prevent bleeding after a large EMR or ESD. Compared to the powders, it doesn't require active bleeding to actually kind of glom on, and it's just going to provide a little like covering over the lesion and hopefully kind of decrease rebleeding. Finally, like really old school, there's like sclerostin injection, which is like just injecting ethanol or ethanolamine, and you can inject that directly to cause direct tissue injury and thrombosis. We really don't commonly use this for non-variceal upper GI bleeding. I've injected this into some rectal varices before, but yeah, not in upper GI bleeding. So this is a summary slide from the ESGE about what their suggestions are for different types of therapy for based on the Forest classification. So again, for actively bleeding, they do suggest injecting epinephrine first and then doing some kind of second modality or using over-the-scope clips as monotherapy. For these non-bleeding visible vessels, again, they suggest monotherapy or combined therapy, but using contact or non-contact thermal therapy, clips, or they still have sclerosing agents in here as well. Again, can't say that we've done that. Adherent clot, they do suggest removing the clot for hemostasis. This might be a scenario where you consider pre-injecting epinephrine in case you do unroof something that's going to start actively bleeding. But then once you remove the clot, treat the underlying lesion. And then Forest 2C and 3, low-risk lesions, no endoscopic therapy needed. What if it doesn't stop bleeding? Or what if it starts bleeding again? The first thing would be potentially repeat endoscopy, and that's been a scenario for sure where you should think about a different therapeutic modality, especially over the scope clips. Another option is IR embolization. Just go and put some coils in the actively bleeding lesion. That is also a good salvage therapy for refractory bleeding. The ESG actually cites some studies examining prophylactic embolization for like very high risk lesions, where like actually after you've already gotten endoscopic therapy, there might be some scenarios where you consider talking to IR and suggestion of like some decreased rebleeding in some of these scenarios, but no clear mortality difference. So certainly not a strong recommendation there. And then finally, in the modern era, surgery is very rare, but in some cases of like very refractory bleeding, people do have to go in and have surgery, like by oversewing, usually actively bleeding also. So if someone who's failed several endoscopies and IR, getting our surgical colleagues involved is still warranted. So I'm not going to dwell on this. This is kind of a summary slide, including the post-endoscopic management, which I'll dive into a little more detail here. But these people with the high-risk lesions are going to get high-dose PPI therapy, and the low-risk lesions are going to get standard-dose PPI therapy. So what do we mean by that? So high-dose PPI therapy is that like 80 milligram bolus and then 40 milligrams IV BID, and we usually consider that for 72 hours. And then transition to 40 milligrams BID for at least 2 weeks after discharge, although we often in practice do it longer. Although the data for long duration PPI therapy is actually really more at the level of expert opinion. There was only one trial basically where they switched these high-risk patients to 40 milligrams once daily after 2 weeks, and that seemed to work. But certainly for larger ulcers, we often do recommend 4 or even 8 weeks of BID PPI. For lower risk lesions, these patients generally can be discharged right after the endoscopy, and they can be just on standard once daily PPI therapy, usually for at least 4 weeks. With the exception being that if you actually have documented H. pylori infection, you actually only need to treat the H. pylori, which involves 2 weeks of PPI with antibiotics. And once you've removed the H. pylori, which was causing the ulcer, they actually don't need long-term PPI beyond that. So this, for different etiologies of peptic ulcer, for the H. pylori, we're going to treat it and then make sure we document that the H. pylori was eradicated, and then you can stop PPI. For NSAID-related ulcers, we're going to stop the NSAIDs, initially, and then if they do need NSAIDs for, RA or some other indication, ideally try to use a COX-2 selective NSAID if possible. But in any case, definitely continue PPI indefinitely for as long as they need NSAIDs. As you're all probably well aware at this point, there's really not any indication for aspirin for primary prevention at this point. So if anyone is still on aspirin for primary prevention, stop that. But if someone needs it for secondary prevention, we do want to get that restarted as soon as possible after hemostasis, because there is clear evidence of increased cardiovascular risk with delayed resumption of aspirin in people who actually have had an MI or stroke. And then for the truly idiopathic ulcers where you don't know what caused it, we are going to continue PPI therapy in the long term. Generally, restarting diet usually will start with clears. Most people, certainly within 24 hours, it's recommended to start that. I think someone who is extubated, stable, I'll often start clears earlier than that. But definitely don't keep your patient's NPO for more than 24 hours post endoscopy. There's not really any data to suggest that you need to do that. And then the other thing to really think about is iron. So, iron deficiency anemia results from over half of upper GI bleeds, and really anyone who bleeds down to lower than 7 to 8, like they're almost certainly going to deplete their iron stores as they try to rebuild their hemoglobin levels, and so they're almost certainly going to become iron deficient. Remember, if you check iron studies in the acute setting, the transferrin saturation is going to increase after transfusion, but the ferritin is more of your marker of iron stores, and that is not affected by transfusion. So you can still diagnose iron deficiency anemia in someone who's gotten a transfusion if their ferritin is low. Also remember that transfusion alone is not adequate to replete iron stores. There's a little bit of iron, obviously, in the red blood cells that you're giving, but once those lyse, maybe you can salvage some of that. But by giving transfusions, you're not doing anything to actually replete their underlying iron deficiency. So you do need to give iron either orally or IV as well. And there is actually been a couple of RCTs of IV versus PO iron after acute GI bleeding, which, as you can see here, there was a greater increase in the hemoglobin level, much faster normalization of their iron stores, and it really increased in really most of the quality of life markers that they studied here by 6 weeks with IV therapy. So I do highly recommend anyone who's here with an upper GI bleed who either has been found to have definite iron deficiency or at least bled to a pretty significant level, that you give them IV iron while they're in the hospital to start repleting their iron stores. Finally, as Gloria mentioned earlier, we do often recommend doing a follow-up upper endoscopy in people who have severe esophagitis to make sure that healed and to rule out underlying Barrett's. And then anyone with a gastric ulcer that's large, that has suspicion for malignancy or risk factors, if we didn't biopsy it on the index endoscopy to rule out malignancy, or you're not sure what caused it, these are all scenarios where you definitely want to make sure that gastric ulcer heals. Someone who, for example, is taking NSAIDs and has a couple of small, clean base gastric ulcers, those almost certainly are not going to be malignant. You're pretty unlikely to get a couple of different small ulcers and have that be a cancer. And so in that scenario, you stop the NSAIDs, they're doing fine. Maybe you probably don't need to rescope that patient. But as a general rule, think about gastric ulcers, repeat endoscopy. Duodenal cancer is extremely rare and does not presents as a mass, not as an ulcer. So generally do not need to rescope patients with duodenal cancers. All right, and this is just a summary slide that's in the ACG guidelines as well. So I'm not going to link it, but this basically covers essentially everything that we talked about. So in summary, the key clinical features of upper GI bleeding are the quality of the bleeding, how stable the patient is overall, most common causes being peptic ulcer disease, erosions, esophagitis, obtain that good history, start resuscitation early with those large bore PIVs, pretty limited role for urgent endoscopy. Really, it's those patients who are in refractory shock where hemostasis is necessary to help stabilize the patient. Do give PPI before endoscopy. Overall, it doesn't affect mortality, but it certainly does make your job easier. And try to remember to get prokinetics if you can, especially in people with active bleeding. And then endoscopic findings are going to dictate your endoscopic therapy as well as what you do after endoscopy. And anyone who bleeds after as a recurrent bleeding, scope is generally our first line go-to, but also have options like IR as a backup. So remember, we just said, you always have help available. We never mind being called about these patients overnight. So please reach out to your attending and triage. And we have 1 minute to go for questions, so I'll end there.